Hello, my name is John Wilding from the University of Liverpool, and I'm going to talk about whether we've reached the limits for the treatment of obesity with GLP-1 receptor analogues. We know that weight management is difficult. The first thing we have to achieve is, of course, weight loss through diet and physical activity, but the challenge is maintaining that weight loss and preventing weight regain so that we can achieve the long-term benefits of weight loss, including, for example, improvements in diabetes, cardiovascular risk, improving functional impairment, and ultimately improving people's quality of life. The reality, though, is that maintenance of weight loss is challenging, as we can see here from a number of clinical trials where weight loss has been achieved over a year or so, but in the long-term follow-up, we tend to see weight regain. Why is this the case? We know that if we go on a diet, there are physiological changes that tend to push us back towards our previous body weight. These include reductions in the fat hormone leptin that signals appetite to the brain, and also changes in gut hormones such as GLP-1, a satiety hormone, and ghrelin, the hunger hormone, that tend to make us feel hungrier. We also see reductions in energy expenditure that tend to mean that the body tries to conserve energy. As a result, people have tried to look at whether it's possible to help maintain weight loss using pharmacotherapy as an adjunct to diet and exercise. And we currently have 3 pharmacotherapies approved within the UK and the European Union. These include orlistat, the intestinal lipase inhibitor, which is moderately effective but not tolerated because of its GI side effects by some people. The combination of naltrexone and bupropion, a centrally acting agent, which is not widely used and not approved by NICE in the UK. And finally, we have liraglutide 3 milligrams, a GLP-1 receptor analog, which is approved by NICE for use for some people with obesity in the UK. GLP-1 is an interesting molecule. We know that it is used widely for the treatment of diabetes because of its beneficial effects on insulin and glucagon secretion. But it also has important effects on the brain to reduce appetite and is part of the satiety cascade that I described earlier. So if we use GLP-1 receptor analogues as potential treatments, they do seem to have effects on appetite. Here we can see a study using liraglutide at the higher dose of 3 milligrams that is approved for weight management, demonstrating that it is able to reduce energy intake during a test meal situation, but that it does not have effects on energy expenditure. The reduction in energy expenditure here is due to the energy conservation that occurs with weight loss. In clinical trials for the treatment of obesity, liraglutide has been shown to be consistently effective at producing weight loss of, on average, between 5.7 and 8%, compared to much lower percentage weight loss with diet and exercise alone, and that about half to 60% of people are able to achieve clinically relevant weight loss of 5% or more. Can we do better than liraglutide? Well, semaglutide is a weekly GLP-1 receptor analog, and this was tested in the STEP trials. I'm going to focus here on the largest trial in the STEP program, the STEP 1 trial, that randomized people with obesity, without diabetes, and who had not had bariatric surgery or recently used other weight management to treatment with semaglutide or placebo. We can see here that on the background of lifestyle intervention, the follow-up was for 68 weeks, and patients were randomized 2-to-1 with semaglutide or placebo. Let's turn to the results. We can see that in the placebo group, the weight loss was around 2.4%, compared to 14.9% with semaglutide in the intention to treat analysis, and slightly greater weight loss if we look at the 90% or so of patients that maintained on study drug during the course of the trial. Another way of looking at this is to see how many people achieved weight loss of 5% or more. This was achieved by 86% of people with semaglutide 2.4 milligrams, compared to just 32% with placebo. More than 2/3 of people achieved a weight loss of 10%, more than half a weight loss of 15% or more, and nearly a third achieved 20% weight loss with semaglutide in the intention to treat analysis. This was associated with improvements in body composition, as seen here in this sub-study using DEXA to measure body composition, where we see reductions in total fat mass, reductions in lean body mass, compared to no significant change with placebo. This translates into improvements in risk factors and other outcomes. So we see reductions in waist circumference, reductions of 6 millimeters of mercury in systolic blood pressure, and improvements in physical functioning using both the SF-36 and the impact of weight on quality of life scores. We also see improvements in lipid profiles with reductions in total and LDL cholesterol, as well as VLDL cholesterol and triglycerides, and improvement in the protective HDL cholesterol. Interestingly, we also see reductions in inflammation as measured by C-reactive protein. In terms of adverse events, what was seen in the STEP 1 trial was similar to what we expect with GLP-1 receptor analogues, with nausea, diarrhea, vomiting, constipation occurring early during treatment but tending to resolve over time, and a small excess of patients experiencing gallbladder-related disorders, as we expect with any intervention for weight loss. If we look across the STEP program, 4 of these trials have now completed, and we can see pretty consistent results. STEP 1 shown here, STEP 2 in people with diabetes, slightly less weight loss, but nevertheless quite impressive at 9.6%. When we combine semaglutide with intensive behavioral therapy, we see a little bit more weight loss. And in the sustained weight management trial in STEP 4, we actually saw 17.4% weight loss, but of course weight regain when the treatment is stopped, which is of course what we expect with any weight loss medication. Of course, showing reductions in risk factors is all very well, but what's important is reductions in events, and this is being tested in the ongoing SELECT trial, which has now completed randomization of 17,500 people with pre-existing cardiovascular disease to semaglutide or placebo, and with the outcome of 3-point MACE, which will give us some results in about 3 to 4 years' time. Can we do better than just semaglutide? Well, here we see a study with a GLP-1 receptor, GIP receptor analog called tirzepatide in people with diabetes. This is just a 26-week study, but we see very impressive reductions in HbA1c compared to the GLP-1 receptor analog liraglutide, as well as 11.3 kilograms of weight loss compared to just 2.7 kilograms with liraglutide. This agent, like others, is associated with nausea, vomiting, and diarrhea, but is being tested in a comprehensive phase 3 program. Another possibility is to combine semaglutide with another gut hormone called amylin. And in this 20-week trial, we can see that amylin was associated with a 17.1% weight loss when combined with semaglutide, where 2/3 of people achieved a weight loss of at least 15%. So it looks as though we can now get much closer to the sort of weight loss that we see with bariatric surgery. We're already in the range of the sleeve gastrectomy with semaglutide, but I think with combining GLP-1 receptor analogues with other gut hormones, we may get close to what we see with a Roux-en-Y gastric bypass. So to summarize, I hope I've convinced you that although weight loss with diet and exercise is difficult because of the physiological responses to weight loss, that we can use GLP-1 receptor analogues to support people to maintain and achieve higher weight loss, and that we may even be able to reduce cardiovascular disease if the SELECT trial is successful in showing semaglutide reduces cardiovascular disease in people with obesity and at high risk. We may not have yet reached the limits because we also have the possibility of combining GLP-1 receptor analogues with other gut hormones such as GIP and amylin that may produce even greater weight loss to rival bariatric surgery in the future. Thank you very much for your attention.